Thanks, Kayla. Good afternoon, everyone. My name is Kelly Maston, Coalition Manager from the National Association of State Mental Health Program Directors. And I'd like to welcome you all to today's SAMHSA-sponsored webinar titled Crisis Stabilization Considerations for Children, Youth, and Families. And our presenters today are Tim Marshall and Danielle Gasparini. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. When the presentation ends, a brief survey will show in your browser. Please take a few moments to share your thoughts about today's presentation. I'd like to thank you again for joining us, and I will now turn this over to Tim to get us started. Thanks, Tim.
Good afternoon, everybody. Next slide, please. It's great to see so many people joining, and we'll get going and just pause for a second. This is the opening disclaimer with SAMHSA, so everybody is aware of that. Next slide, please. And as was said, I'm Tim Marshall. I'm currently a senior advisor at the Innovations Institute at the University of Connecticut School of Social Work, and I've been working with them for a number of years on implementing, helping states and jurisdictions implementing mobile response and stabilization services in a number of jurisdictions and states around the country. And I formerly worked out of the state of Connecticut. I did work there for over 30 years and oversaw the community mental health system for the last 15 or 16 years, and was instrumental in helping to build the crisis service system there, including our Connecticut MRSS system there. Next slide, please. And you'll hear from Danielle when she does introduce herself when she does her part. And we have these 4 learning objectives that all the participants will learn how the developmental, social, and clinical needs of children and youth are different from those for adults. We'll learn state examples of crisis system enhancements to meet the needs of children and youth with at risk for serious emotional disturbance in their families, in their homes and communities whenever possible. We'll learn how states are using MRSS service to ensure children and families have a safe place to be during the crisis stabilization part of the crisis. And then finally, we'll learn application of national best practice for youth crisis stabilization design and implementation from Danielle in New Jersey. Next slide. So I think it's one of the things we want to all acknowledge, that it was really exciting when SAMHSA released kind of the blueprint for developing the crisis service system across the country. And we really want to acknowledge that work and applaud it. It just was so desperately needed. And we're still really early in kind of the infancy, particularly with the implementation of 988 and all of the crisis systems work that's going on throughout the country, especially state and county infrastructure development. And one of the basic principles is this starting point, that crisis services for anyone, anywhere, and any time. And the 3 taglines that were updated by SAMHSA recently, well, not so recently, but someone to contact, someone to respond, and a safe place for help. And for those of you who might recall when it first came out, and there's still some papers that have the original title on it, that or the 3 taglines, someone to call, someone to respond, and a safe place to be. So that this is kind of an advancement and enhancement to that. And so I think what we're suggesting is that we would like to add to the dialogue around the needs of children and their families as being to enhance the starting point that SAMHSA kicked off with these taglines, and what it means for kids and family, and how that's different than the adult traditional system. Next slide, please. So what we've learned as we're implementing this across the country in a number of the states that have done this, again, particularly here, Connecticut, New Jersey, that you have examples from today, is that for the mobile crisis response system, or the mobile response system for kids and families, the someone to contact and the someone to respond is kind of immediate. We are promoting a best practice of just responding to kids and families when they're in need. And we know in the states that have done the MRSS best practice that the majority of calls coming in from the community come from either parents or schools, but they're third party. Most callers are not the child themselves that is in crisis. The data nationally, I think, is coming in and showing us that children, when they're engaging and we're making contact, they're doing it more through text and chat than they are doing phone calls. Now, occasionally children do call. But when you are calling and responding to somebody in crisis and you're getting a call from somebody that's close to the individual, it puts the call specialist immediately at a disadvantage, and trying to stabilize the person in crisis is now secondhand. So that disadvantage is one of the challenges that we're proposing to overcome with some of these better practices that enhance the response for that. And the other piece that really comes with this territory of children and families and their families is that if you take and you apply what the traditional medical model, kind of institutionally based crisis system applies to children, you're gonna miss quite a bit. And so what we're suggesting is that very often building a response system for children who are in crisis is much further upstream. In other words, you're able to get into situations that may not be as acute or appear to be as acute on the surface. So that's what I'm kind of referring to when I talk about the typical crisis. Next slide, please. So this whole issue is that we're just wanting to make sure that we're able to develop specialized response teams, mobile response teams for all the crisis centers that we can. And if we're going to really make them available, what do we know? Or let me say that differently. If we're really respond to that a crisis services for anyone, anywhere, at any time, what do we need to do to make that specifically available to children and their families, since children are not little adults? So what works best for children and youth and their families? And so that's essentially what we're going to go through now in this series of slides that you'll see. Next slide. So the first thing is that it's a rapid response, that you just go. And the standard that has been established is 60 minutes. Connecticut, we've been very fortunate. We're a small state, so we're very able to get around very rapidly. And our average face-to-face time is around 30 minutes from the time that we receive the call. And every caller is offered the automatic opportunity for face-to-face assessment. Now, we do not impose face-to-face assessments on anyone. There are a number of times when parents call in and just need and want to talk through what occurred, what the crisis is, et cetera. But what we do is offer everyone a face-to-face opportunity to be there from the moment of that call. So literally saying we can be there within an hour, and then so it's a rapid response, and it's happening at the moment that the caller is calling. So that could be real time, and often it is in real time, but sometimes it could be afterwards. And then we'll be referring to other best practices that have been established to the MRSS national model. Next slide, please. So this is a good example, and we try to pair the practice of MRSS with the 988 system, because right now there's a number of jurisdictions that are implementing both, and being able to implement a mobile response system for children and youth that then is available for the 988 system to send out immediately is like the gold standard of having an intervention very rapidly, rather than just only exclusively as a telephonic intervention. So as we said, it starts off with the call. Mostly at time, again, it's most commonly parents, caregivers, or custodial caregivers like schools, and they're calling for help. And as we shared, the practice would be that anytime 24/7, that there would be a face-to-face opportunity to go directly to the house. And there's no definition of what rises to that face-to-face assessment, that any call is important enough to respond. So if you have a parent or school personnel or other concerned adult who's calling a stranger, the public serving system to help, then that's a crisis. And so we want to say 100% of the time they're offered that face-to-face response and a rapid face-to-face response. And that's what the clock is for, that within that 60-minute period of time, there's going to be somebody there. And then finally, the next stage after and during that period is that the number one goal is stabilize that child at home, in their community, and remain in their school. So we really work really hard to do everything impossible to work with the natural and informal supports, the connections that the family has, as well as the professional community and the full service array that supports the crisis face-to-face intervention that could occur, or the mobile response face-to-face intervention. The next would be the system that supports. That's the part that, rather than thinking about a place to help or a place to be was the old one, our starting point is the place to be, or the place to help is home, in the community, in school. And that the whole system supports that response face-to-face. And then if you do this, the farthest column on the right is that we demonstrate through the data of a number of states and jurisdictions who are doing this, that you reduce arrest rates, incarceration rates, ambulance, hospitalization, ED visits, and outcomes for children and families improve dramatically. Next slide, please. So this slide here that you see visually, we're now going to just walk through and support with some of the slides. So the MRSS opportunity, the mobile response system for kids and families, enhances the opportunity to talk, if you will, the telephonic, and by responding and being face-to-face. So you kind of join those first two taglines together immediately. As I said, the crisis is then defined by the family and the young person. There's no screening out, there's no triaging. It's just directions, some quick, making sure there's no, weapons, there's no danger of any kind. And then it's getting to do the face-to-face assessment. It's 24 hours a day, 7 days a week, 365 days a year, and it's immediate. And the people who are going are trained in children's issues, appropriately trained with the developmental phases that kids go through and their families, so that we know that when any individual goes into crisis, it has repercussions on all those around them. And particularly when it's a child in a family unit, it's going to have an impact on both the parents and siblings. And if the child's experienced this at school, they're probably impacting classmates as well as school staff, including teachers. We work really, really hard that it does not include law enforcement, and only in the most challenging situations for safety would law enforcement need to be invited or go with the MRSS team. And then it would be communicated to the family that was occurring, unless it was a dangerous situation to do so. So it's a developmentally appropriate assessment that really takes into the needs of both the child and their condition within the context of the situation that they're in, the challenge that they're calling for, as well as how it's impacting the family and those around. Next slide. So here we talk about the call center component, the first 72 hours, and then the following is, so these three phases, if you will. So it's that immediate response, again, is we move those two pieces together. We move rapidly through the telephonic triage process, trying hard just to get the basic situation. What is the caller calling about? Why is there a risk right now? What is the challenge? And we just are trying to assess to be sure that there's no need for some larger intervention. And as I said, usually it's is a need for an ambulance, or is it a need for law enforcement because there's weapons or there's an injury, there's somebody's bleeding, et cetera, et cetera. But the 72-hour piece is that within that face-to-face assessment, in that rapid face-to-face assessment, in that first within that first hour, that up to 72 hours, and in Connecticut, we use 5 days. The first 5 days, there's multiple visits if necessary, making sure the acute phase is stabilized. And then we transition it to a 6 to 8 week period of stabilization. And the best practice, we promote the 8 weeks, feeling like if you are doing 8 weeks and things are stabilized in 6, then there's no reason why you can't transition out. But you work really hard in that last phase to make sure that there's a full system, a full service array, comprehensive system that is really supporting the ongoing stabilization and handoff to whatever comes next, or transition to whatever comes next. So that's really important for that connection to remain at home in the school and in the community, and using both the natural and informal support network that were normally there, and that sometimes the families lost connections to, and you rebuild those, but also use the professional community as needed. Next slide, please. So just again, this enhanced approach is that you're screening immediately and assessing for that initial risk and imminent harm, and then you move right into the family story. And then once that is taken, it's transferred, warm transferred to the local responder, who then the situation is not needed to be repeated by the caller, that it's repeated by the first, the call specialist, and then the responding clinician takes that information, builds and begins to engage, and then is on the way and getting to that face-to-face moment and beginning the assessment process. So just move rapidly from the screening, the listening, the engaging, getting the details, and then doing the face-to-face assessment, again, offering it 100% of the time. Connecticut, we average about 92% of the time, and it's those 6 to 8% of the time that the parent or the caller is just saying, hey, we just want to talk this through for a second. Next slide. So the key tasks, again, like many, but with children in mind, is to de-escalate the most acute part of that, establish safety, and start to soothe in whatever developmentally appropriate way that is. Even for older kids, you wouldn't necessarily use the term soothing with them, but essentially you're trying to just pull them out of the acute phase, and then you continue on gathering your information, supporting your assessment, bringing you to the crisis safety plan, and beginning to plan for entering into the stabilization phase, and what is the greatest need, and what would be supporting that greatest need. And very often what is needed is, it's not uncommon for the child not to be ready for it. So the need could be there, but the child may not be prepared. So during this stabilization phase that we'll talk about in a minute, it becomes really, really important to help ready that. But in this first 72 hours, and as I said, in Connecticut, we may have multiple visits within the first 5 days. It's gaining all this information and just establishing that engagement and safety and trust to be able to move through the rest of the stabilization phase. Next slide. So yeah, so here are another 6 pieces of that. Someone to respond is a piece of stabilization, is that it's very symptom and solution focused, and the goals get integrated into the individualized plan of care. So again, you move from the acute phase into the stabilization as rapidly as we can, and prepared. And you, in your crisis safety plan, you're doing both proactive and reactive safety planning. So once you get the child stabilized, it is possible that that child might go into another acute phase during the 8 weeks. So you want to make sure that the family's able to respond to that period in a way that is really helpful. And it may be that the MRSS staff person, the responder who's assigned to work with that family, will come out multiple times or be contacted directly to come out in another acute situation. So the plan of care is developed, and it puts the family and the child at the center, and it makes them active partners in the development of that, and re-empowers them and rebuilds those connections back to the community and their home. So that reconnection is so often so helpful that we often think that many kids with serious mental health challenges can't participate in the typical kind of after school activities, whether it's sports or arts or music or whatever that may be. But it's so important to help kids with mental health challenges to get reconnected. And if there are things that got in the way, there was barriers, let's help to reduce those barriers and get them connected. And sometimes it might be with some extra support, but it becomes so important. It also is necessary, again, if needed, to engage the professional community. But when you have, my experience in Connecticut is the more skill you have with the MRSS staff and the competency development you do in the workforce development phase, very often families don't need big clinical interventions. Yes, they sometimes do. So those are always there. So the intensive outpatient, the intensive in-home array, the evidence-based practice array, and even the intensive evidence-based outpatient kind of arena are all necessary pieces. But it's amazing how often that families just need some more support to connect back to informal and family supports, natural supports that were there and that somehow eroded away. So it's really important to do both the natural and the professional, and then always paying attention to if there's a higher level of need and to connect them to it. But the MRSS system, that stabilization phase, is really, again, designed to help prepare the kid, the child, and the family for whatever that, and if whatever that next level of care is. And in that transition, if it has to be one of the heavy-based institutional care, that you can predict and help prepare for what is often very traumatic going into an inpatient setting or a PRTF or psychiatric residential treatment. So those pieces are really necessary. Next slide, please. So these are key tasks: to engage, to plan, to monitor, to adjust, and to do the support and the care. So those are, again, the basic parts that you're doing, and you're doing this throughout the time, both in the acute and in the stabilization phase. And it's really important to be engaging and doing this throughout the stabilization period. Monitoring and adjusting is really, really key. Paying attention to what the child's needs are and how the family's responding as the child gets stabilized, and how do we continue to support the child while they're at home, in school, and the community, and to prevent any of those high-level organizational crisis care. And finally, this ongoing support. Next slide. So safe place to be. So this is the part that we feel strongly that it's best to have a full system to support, and a more comprehensive system you have, the more options, the more tools in the tool belt, if you will, of the MRSS staff and those who are responding face-to-face in a mobile way. So this is a really important component of that. And one of the parts of the MRSS system is, during the low periods, which tend to be the summer months, to be sure you're connecting with all your major system partners. And so that's, and then the other part that starts to happen when you start to make those connections and those linkages to the community, and the more work you do in the community, you start to identify where there are gaps in the service array. So the main part of the full system to report is it's grounded in the system of care values and principles. And we really work hard, again, maintaining kids at home, maintain them in their community, in their school, and keep them safe. And that it's only the very last resort when needing to go to hospital level care. Next slide. So the values, again, as I articulated already, keeping them within homes and communities. Services are developmentally appropriate and not just doing what you do for adults, whether that's in the actual crisis moment or whether it's also follow-up after the acute crisis is stabilized. kids are not just little adults, and they very often the adults intervention sometimes could even be harmful for kids. It's really, really important to engage kids and families and young adults who have lived experience to help understand what their experiences were and to help plug the gaps and identify the gaps that might be in the community service array that needs to be enhanced and supported. And then always being both cultural and linguistically responsive and paying attention to health inequities so that they can be very equitable, particularly when it comes to sexual orientation and gender diversity. Again, it's another specialized population that you need to develop special competencies with for the MRSS staff. Next slide, please. So again, we are validating, responding, and supporting parents and caregivers, and just by being there immediately, taking seriously their calling for help, supporting the schools and being a major system partner. In Connecticut, we can only work with kids up to age 18, and we know some kids in schools are over 19. And so what we do when there's a call for an older youth, we respond to the school, and the school becomes the customer, if you will, or the client, if you will. The child we wouldn't see, but we would just offer some consultation and support to the school and try to do some outreach, if allowed, with appropriate releases, to connect the older child to the system that could to support the older youth that might be still in school. But also these other big points of connection, both emergency department, schools, juvenile justice, child welfare, your agencies who oversees intellectual and developmental disabilities, and then really working hard, again, to avoid unnecessarily trips to the emergency department or even going into inpatient. And we put a high premium on linkage and connection to high fidelity wraparound. Next slide, please. We also highlight here, just as we want to say that there's a specialized need for children and their families as different than adults. Within the whole continuum of children, there's some specialized needs, and your response to a child who might be in crisis or having some kind of malfunction from 0 to 5 may be different than 5 to 12 and different from up to 14. So all the developmental phases needs to be attentive and paid attention to. Next slide, please. And this becomes really important with since the pandemic and the need for having a comprehensive student mental health support to the schools that you serve. So in Connecticut, what we do is each of our MRSS providers are required to have good working relationships with each school district in their territory, and trying to support schools in the development of their own comprehensive mental health, student mental health system internally becomes really important. And so it's that both internal, external support. So when schools have that support internally, the MRSS team can capitalize on that, make some connections and linkages within the schools, and then also when it's needed in the community. So you have that direct linkage to the community-based service array. So there may be, for example, CBITS or Bounce Back, the cognitive behavior intervention for trauma in schools, or Bounce Back, which is for the younger kids. And you're responding to a kid who's exposed to trauma, that would be a good linkage, for example. So the notion being here that schools are part of that full comprehensive system to support and maintain children at home in the community. Next slide. So the intensive in-home array, again, Connecticut happens to have a very rich and robust alphabet soup of intensive in-home. Here's some of them that we have used over the years. We have others also, but we try really hard to do the mainstay high fidelity wraparound with care coordination, and try to, again, build the most support using natural and informal supports, and then as needed to turn to the professional service array as needed. Next slide. And here's the other, as we get higher into acuity, we want to also be sure that your system can be responsive. So it's not just your MRSS teams that should be the experts in crisis response. Every single service in your service array should have expertise in responding to kids in crisis. And so this is really important that as an outpatient system, you should be able to see walk-ins, and you should be able to have rating systems. Is this within a 2 hour, within a 2-day or 2-week, for example, and be able to work with anybody in crisis who presents themselves. Also, we want to just talk about utilizing the evidence-based practices within that comprehensive outpatient service array. Next slide, please. And the safe place to be, this is the best practice operate crisis receiving a stabilization. This is from the behavioral health crisis care that I referenced on the bottom. I just wanted to put that as it's based in the recommendations from SAMHSA. Next slide. And that really I want to highlight here that the 23-hour crisis assessment center, those of you who participate on the crisis jams on Wednesday, yesterday there was a fabulous presentation on Arizona and Dr. Belfour, and they went through that. Although they reference kids and children in their data, most of what they were talking about, however, was really an adult-driven model. So when you talk about having 8 or 10 police cruisers dropping off adults at any time, that's an adult-based model. So the point here that we're highlighting is if you're developing these 23-hour crisis assessment centers, one size does not fit all, and you really need to develop a specialized center specifically for children and their families, with a key component being that parents remain with their children while there, when it's safe. Obviously, if there's protective service issues, that's a challenge. But the bottom line is when kids show up at these 23-hour settings, that families should be there. And the interaction between your 23-hour and your mobile response team should be back and forth. So if the mobile team can't maintain the child at home in the community, the 23-hour assessment center should be the next step. And at discharge out of the 23-hour, the child should be referred back to the MRSS system to support the child back at home in the community. And only again at the very last resort to a crisis, a short-term crisis residential. But again, hopefully avoiding ED and inpatient as best as possible. Next slide. This again is the same slide I showed you before, but the number one point here is that added blue bar across the bottom, that MRSS has a huge role in being one of your main reductions of suicide in your system. So they should be, your MRSS staff should be fully trained, comfortable, and knowledgeable on best practices for both intervention, postvention, and prevention. And so that it becomes really, really important to connect your MRS system with your suicide prevention coordinator and your suicide, your county and state coalitions, and that people should know how quickly they can respond. In Connecticut, both the adult and the child serving mobile systems are notified for a death of a child youngsters 24 and under. And both systems are notified in real time, and we stand up teams and alert both the community and the schools if the child was in school, or if the school's impacted, had siblings in there, that there's responders available to reduce the contagion effect. Next slide. So in summary, we want to just add to the conversation, add to the literature about the developing an crisis response system across the country, call out children and their families as kind of a special population like so many others, and that really how the best practice of a mobile response system for children and families that is a just go approach, and it's responsive to parents and caregivers, how much that could be the backbone of your full service array, and then work towards maintaining kids at home and in their communities sidestepping visits to the emergency department, boarding kids in the emergency department, adding additional trauma as a result of the emergency department, as well as avoiding inpatient stays. Inpatient stays, although are necessary at times, can still be very, very traumatic. And in so doing, you will reduce your juvenile arrests, your detentions, your ED visits, your hospitalization days, and your inpatient days. Next slide. This is our references, and we will have questions afterwards, so I'll turn it over to Danielle. So thank you all.
Thank you, Tim. My name is Danielle Gasparini. As mentioned before, I'm a licensed clinical social worker, and I've been working in mobile response for 15 years at CPC Integrated Health. During the last 15 years at CPC, I've also been involved with various children's programs that we've had here through the agency, including children's partial care, conducting parenting groups, overseeing programs that have been in our local school system. In addition to that, I'm an adjunct at Monmouth University, which is a school local to me. I've had private practice experience, and then prior to my time at CPC, I worked in the school system in a school-based program and gave direct counseling services. And then before that, I actually was the coordinator for a pregnancy, an adolescent pregnancy prevention initiative at a local school system. So that's a little bit about me. And then just my love for this program and just the successes that it has brings me here. Next slide, please. So in social work, we're taught that we meet our clients literally and figuratively. We meet them literally where they are, but in mobile response, we mean that quite literally, but also figuratively. So what do I mean by that? I guess that sounds a little confusing, but we meet a child, we meet a family where they are in terms of readiness for treatment, their level of insight. But with mobile response, like Tim was saying, we meet the family, the child, where they are in the community. And that could be anywhere. That could be at their home, it could be at school, it could be at the local police station, it could be in a public place at a Dunkin' Donuts. It doesn't matter. The idea is that we are meeting the family where they feel most comfortable meeting with us, and a place where they're ready to tell their story to us. The other really important component is that a crisis is subjective, and we allow the families to define their crisis. And on the next slide, I'm going to go over some common reasons that families call us, but not yet, I'm sorry. There's a little intro, go back, sorry. But I want to first talk about what it means to be a self-defined crisis. We all have our own elasticity, and that really varies on what obstacles we're currently having in our life, or what pleasantries are thrown our way. So from time to time, our elasticity in terms of what a crisis is or isn't changes. And so we want families to define the crisis and not have to go through a list of criteria that might keep them from accessing the services or serve as an obstacle. Families don't have to compare their situation to a neighbor or a family member if they feel that the situation is rising to a level of crisis for them, that they feel that they can go ahead and call for services and that we'll be there to help them. This is really an important element in really allowing families to access a service and not feel that what they're experiencing isn't serious enough. We want to get to families, we want to help children before the problem gets to be too great. And so the sooner that we can get in there and help, the better. And that really echoes our approach of family voice and choice. So the child, the family, they're equals, they're partners on our treatment team, and we want to hear their voices and have them part of the solution, part of the treatment planning. Our programming is, 72-hour stabilization or 8-week stabilization, just depending on what the family's needs are at the time, which is really important because, again, we want families to help drive what that service looks like. Our initial meeting is very, very productive and therapeutic. We allow time for the caregiver and the child to share their stories, tell us about their crisis. Of course, like Tim mentioned, sometimes a child is reluctant and they're not really ready to tell their story right away, and that's okay. There's time for that to as they go along, to give us those insights about what brought them to the crisis, and we don't have to push. Again, we're meeting them right where they are. We also complete a crisis assessment, and this assessment highlights their needs, and we're looking at all the domains of life. We're looking at every area, and we're also looking at the caregiver. What do they need to support the well-being and the success of their child? So we look at them and what they might need, and what we can do to support them as well. In this very first meeting, like I said, it's very productive. We also create a safety plan. And this safety plan addresses any concerns that bubbled up to the surface. And it also outlines some tools, coping skills that can be utilized for the youth and family. The plan is not meant to be exhaustive. It's really meant to bridge the gap until the youth and family can be linked to further therapeutic services. Depending on what the needs are of the family, like I said, we might stay involved for 72 hours, a kind of quick stabilization crisis period, or that full 8 weeks. And again, this is voluntary. Families aren't pressured. We work together with them to figure out what makes sense for them, and what meets their needs. Each week at a minimal, we check in with the family and the provider that they're linked with, any providers. And we ask about new risk factors. We ask about progress or lack thereof, what else they might need from us to help with their success. We lend our ear, we validate their concerns. We're there, we support them on those tough days, but we also are there to be their cheerleaders when they tell us some successes that happen. I can tell a brief little story. Yesterday, I was at a school meeting, and I'm going to reference this meeting a little bit later too. And we met with this with a school, and we were, hearing about how this child was progressing. And the teacher told us that he was having a tough time, and he asked to go out into the hallway. And when she went out to meet him, he was doing some box breathing, and she was like, "Wow, look at you." She's like, "Yes, my therapist taught me this when I get upset, and I remembered to do it, and so I'm calming down." So it was so great to hear that he was using that coping skill and remembered right away. So those are the important things that I love to hear, and to know that there's success happening. And so we do support them. We go to school meetings, we go out and we can do multiple visits, like Tim was saying too. We're not just, go out that one time and that's it. We're really there to be what they need in a very individualized way. So it's not cookie cutter at all. I have this example that I like to use to explain what mobile response does, but I have to have a little disclaimer that goes with it. So here's my little disclaimer. I'm not very musically inclined unless you consider me singing off key to 80s music in my car as being musically inclined. But I feel like this example really helps to talk about what mobile is. And my mother-in-law was a music teacher, so I feel like I can kind of use this music example through her. So anyway, here's my little example. I feel like mobile response acts as like a conductor in an orchestra. They check to see who is all coming together for the family, just like musicians come together to play. And they check in with all of them. They keep all of them informed so they can all work together in this harmony that helps us support the family. No one is doing anything individualized. They're all working together to support this family. So in the end, we have this great collaboration that supports a family. And that's how I like to explain what the mobile response worker does when they go out to a home and engages a family, and what they do for that continuing 8 weeks of ongoing stabilization services. Next slide, please. So if you recall, I said the family defines the crisis, but I also stated that I would give you examples of different reasons that people call. So the reasons that people tend to call mobile response, they might have a child, then they're struggling with their developmental or intellectual needs. Their child might be refusing school, skipping altogether, or just getting there late. There might be some physical or verbal aggression within the home, or maybe the child is being bullied or bullying others. There could be some family conflict, fighting within the home. The youth could be using substances. Maybe they're not complying with household rules, or not obeying a curfew. But I think the most important bullet on this slide is that last one. And the reason why I like to highlight it is because I think it's so important that if a caregiver feels that there's something amiss, something that's off with their child, that they are the expert on their child. And that's good enough reason to call. That could be that self-defined crisis. And I think this is so important as we discuss these services and how they work and who should access them and when. And again, that last bullet is so important because the sooner that we can get a child the help that they need, the better the outcomes are. I'm going to, next talk a little bit about how you access care, but I want to lead with this before I go into that. I always like to make sure that I manage expectations of a family when they go to make the call. I think it takes a lot of courage to call a 1877 number to ask for help. And I want families, I want to take the fear away from that process and make sure that they're prepared for the call, and they know what to expect and they don't get frustrated. And I think by managing these expectations, we lower the temperature, we help put them at ease when they go to make the call. And I think that's really important part of the process. Next slide, please. So there are 4 basic ways that services are typically accessed. So a parent, a legal guardian, or a caregiver can call our central system administrator, and they can call and seek services for youth up to age 21. Of course, over the age of 21, the youth has to be present and consent to those services at the time of the call. A police officer can also call on behalf of a family with the family's presence. So for instance, for this one, say an officer was called out to a call because a child had left the home and they didn't tell the caregiver that they were leaving, and the caregiver was very upset, and the police wind up bringing them back home. And this might be, say, something that happens, often, and the officer remembers that there's this service called Mobile Response, and they say, hey, listen, I'm going to call this number with you, and these counselors are going to come over, and they're going to talk to you guys and see what kind of services they can offer you. So an officer can go ahead and make that call with a family. Schools can also help a family call. Again, the family has to be present, but a school counselor, a school principal can go ahead and make the call to the CSA with a family member. So they can do that on a conference call, or they can sit in the same room and do it, as long as they have the parent there in some form or shape or form to give consent. They can go ahead and even be part of the call process. I had mentioned about managing expectations. When families are calling to get services, a clinical record is created. And so one of the things that's important for families to know is that, this call is going to take about 20-30 minutes. So it's not going to be a quick 5-minute call. And what's going to happen when they're calling is they're going to ask to spell their name, and they're going to spell it back to them, right? So kind of this long, process to make an accurate record. And I always tell families that as, I talk about the service, and when I, go to schools and explain the service and how they can help families access it, I always talk about this important part. Again, because we're managing expectations, we're letting them know what to expect. And this really helps them know that we're there for them and we're not trying to, throw any punches or confuse them along the way. Let's see, we are open 24/7, 7 days a week, 365 days a year. There's always someone there to answer the phone. So families don't have to worry about, gosh, am I going to call before the office closes, or, I have to wait till Monday morning, it's Saturday, and I can't call anybody today. So this is really important to strike while the iron is hot and make sure these services are available when families need it most. Next slide, please. It's funny, with this, there's this rumor that that I have magic words or secret words that help families access this service, and that's not really true. I don't really have any magic words or secret words, but I do have some thoughts of wisdom to help make the call process easier. When we're talking about this service directly with families or with community providers, and we're explaining how it all works, I always, again, reiterate that crisis is subjective, and that families don't need to compare their experiences with others. And I also really try to emphasize that families need to give as much information and detail as possible when they're making that phone call. And I know that this can be really hard and challenging for families. As parents, we don't always want to air our dirty laundry. We want to talk about all the things our child does well. We don't want to necessarily talk about those things that they struggle with. But it's really important that all of those items are shared, so that when we get down to the treatment planning part, we can really do a very good job in making sure we covered all those needs and help children to be the best that they can be, and make sure the services are a good match. And this is true about caregiver needs too. Parents, caregivers, they don't want to necessarily acknowledge that they're struggling, or they're overwhelmed, because they don't want, maybe in some instances, for people to look at them and say, but this is your parent, this is what you need to do. We want to make sure that we know where they're struggling, because we want to make sure that we can support them the same. I guess this is where people think the magic words are. I think it's important to be really honest. So when you're on the phone and you're making this call to ask for services, it's so important to say how you really feel. I need help right now. I need those services for my child today. I really don't think that we can wait for an outpatient appointment. It's so important that someone see me now. And as simple as those little words are, I think it speaks to what's going on with that family in that moment, and how important it is that they get the help that they need then. The other important thing is that we are completely voluntary and at will. So a family can call and they can change their mind. So there's nothing to say that they have to stay with us for the whole 8 weeks. That's not the case. And I think that is refreshing too, because most of our families do stay with us the whole 8 weeks, but to know that they don't have to make this commitment right away, it feels good too. And I think that's helpful for them, because they feel like they have some sense of control during the process, which is always important. Next slide, please. I want to talk a little bit about components of the dispatch. And I already mentioned that we do a safety plan, and I'm going to talk about that in a couple of minutes. But what I really want to talk about are what we call concrete interventions. And they're simply that. They're an actual thing that we leave that assists in some way. And concrete interventions weren't an original part of the design of mobile. it actually became this idea that I had after I took my my son for vaccinations when he was a young child. He wasn't a big fan of shots, like most children aren't big fans of shots. And he wasn't particularly cooperative, screamed a lot, cried. And during all of that noise, the nurse was trying to tell me some possible side effects of this vaccine. He was really loud. I was really distracted by his discomfort and honestly a little unnerved with all the screaming. And so I didn't hear much of what she had to say. But as I was walking out the door, she handed me a piece of paper, which I stuffed in my purse, and it was the information about the vaccine. So of course, a few hours later, he came down with a low grade of fever, and I said, "Oh, I think I have that paper." And I pulled it out of my purse, and sure enough, it had some side effects of the vaccine. I was really relieved to find that paper in my purse, just to be able to read about what she had said that I didn't comprehend in the moment. And that kind of gave me this thought, I can do that with the families, that the caregivers that we see in Mobile. And so the first thing that we did is we created information sheets on some topics, self-harm, ADHD. You get the idea of what we created. We made these really big binders and we put them in all of our agency vehicles with copies. And we explained all these handouts to our staff members, and they started handing them out as appropriate to the parents. And what we found is the parents, like I did with the vaccine information, really liked that they had this very tangible piece of information that they could read over after we left. And the staff really liked it too, because they really felt like they were leaving something with the family too that was going to be helpful. So from there, we kind of thought, I think we can expand on this a little bit. I think we can even do a little bit better. And so we did, and we came up with other things that we could leave with families. We developed a little library of books, and in the back of every car, we keep a stack of books with a variety of topics, including grief and anxiety. My parents are divorcing. My dog passed away. We keep Play-Doh and stress balls. We have these amazing spheres that we teach some breathing techniques. We have safety equipment that families can put on cabinets or doors to help secure, the home. And so these became these wonderful tools that families really, kind of just were so thankful for, that we could provide in the moment. So I had told you about earlier about a school meeting. And so yesterday, I was actually able to give the young boy a journal. He had said that he wanted a place to write down his feelings, because he gets really big feelings, and he just wanted a place to be able to write them, maybe even draw pictures of his feelings. And in the back of the car, I had a few journals. And so I was able to grab them and give him, a choice, and he got his favorite color, red. And he was so excited to, to be able to take that journal and be able to write his thoughts down. And I know that seems silly, it's just this little book, but we were able to kind of do that in the moment for him. I love everything about being able to lead these concrete interventions, and to see that little boy in his journal yesterday just reminded me back of when we came up with the idea. So that's a little bit about concrete interventions. We do have another tangible that we leave with families at dispatch. Next slide, please. And that's our safety plan. And so on the screen here, I put up an example of a safety plan. And so I just want to draw your attention to a couple places on the safety plan. The first line there, it says, what happens with your child that made you call Mobile Response? And this is really important. When I train the staff to write up these safety plans, we really emphasize simple, concise language, no jargon. We want this in the family's words. And you'll also see a little bit further down, it says, what would you like to change as the youth? And what would you like to change as the caregiver? again, this brings us back to that whole idea of we want the family's input, we want the youth's input. And again, this is in their own words. And those two questions are like that magic wand question. If you can wave a magic wand and something would be different, something would change. That's how you ask that and what you put that there. So those are really important because we're really trying to pull out, what the family hopes will happen from calling us. The other things that we put on this safety plan is what might already be in place for a family. So they might already have a supportive teacher or a neighbor or a grandmother or someone that they can go to and talk to. And so we want to tease that out and ask what already helps. Maybe they like to listen to music when they're feeling stressed or anxious. And so that does work. So we want to list the things that are already in place for the youth, for the family. And then we also want to brainstorm together some other ideas that could help the family until we get some more formalized or therapeutic services in place. And so again, those additional prevention and supportive strategies could be some of those concrete interventions that we brought. It could be that. It could be, seeing who else might be available in their in the family's life that they hadn't thought about. Might be someone to lean on or talk to or be supportive, or maybe it's a new activity that they want to try or something they can do together. So all of those components make up our safety plan. And we also like to write the outcome of the visit. So that's sort of our goal, kind of our what's next. So on this sort of fake safety plan here that I wrote up, it's like everyone's involved in, starting counseling, and that mobile is going to help link them with a therapist. So we know at the end of our meeting, we have a goal, and we know what we all agreed to, and we're all going to move forward, and really positive strengths-based language. And that's what all of this is, the safety plan, which I think is so important to make sure that families are having this reminder after we go of what they can do next. And this is meant to be a reference guide to maybe put on the refrigerator or put in a safe place where they can reference it and say, wait, what were those coping skills that those mobile response workers said when they came to the house? Let me pull out that piece of paper. Let me see, wait, how do I use that breathing sphere that they brought along, and help me kind of, calm down. So that's what the safety plan is about. And, families do refer to it. And one of the things that we like to do is, within those first 72 hours is call the family and review the safety plan with them. So either one of the folks that went out to the home to have the visit, or one of our other CIS or crisis intervention specialists will call the family and say, hey, I'm just calling to check in and let's review your safety plan as a reminder, which I think goes a long way with families. In case they did stick it someplace, they're going to go dig it out and, put it in a place where they can access it regularly. Next slide, please. Thank you. So I probably have said the word services quite a lot. And so what do I mean about services? So of course, services are what might already be in the community in terms of services we link to, like outpatient counseling, psychiatrists, APNs, intensive outpatient treatment, partial hospitalization programs. But also we do have access to these in community programs, counselors, IACs, and behavioral assistants that can go into the homes and meet the family, just like Mobile Response did. And this is designed to be brief, but intensive. So this will only really last those 8 weeks. But it can be intensive, meaning a couple hours a week, as opposed to maybe a 15-minute once a week or every other therapy session that someone might have after they're stabilized. So this is really great because I think it really decreases the barrier to services, because we can go and meet have the therapy sessions, meet the family where they need to be met, and not have to worry about getting to an office and what that can entail. So I think this is a really important component, especially for a youth who might be a little reluctant to begin those services. This is a nice way to start And it gives them freedom too, because they can even, sit outside on nice days and not necessarily have the therapy inside a house, or they can meet at a library or a place of convenience like that, which I think is pretty important. Next slide, please. So why do I love this program? Or I guess in other words, what makes Mobile really successful? There's a few things. There's a single point of access for families. We're available 24/7, 365. And there's a toll-free number for the entire state. So it's not like there's different numbers per regions that have to be memorized or anything like that or looked up. It's one number. Our assessment tool, I think, is really what makes this approach so successful. Our staff have to recertify on it every year, so it makes it a reliable and valid tool. We are not only capturing the needs when we're using that tool, but we're also capturing the strengths, which I had mentioned prior, which is really important because we want to build on those strengths and we want to use them when we're doing our treatment planning, so that we can make sure we have a solid plan that really, doesn't reach too hard or too far too quickly. And, again, like I had mentioned before, we're also looking at the caregiver and their needs, because again, it's just, if you think about that old adage about on the airplane, when the oxygen masks come down, we have to make sure that the caregiver, right, is ready and able to help and support their child. And so we're there to help them and support them as needed as well. Next slide, please. So what makes this program successful in terms of implementation? So what makes Mobile work is that we are all about our community partnerships. Who are we partnering with? The school, our past departments, law enforcement, the family-based organizations in our counties, parent-teacher organizations. How do we do that? How does that all work? We, and when I say we, I mean our system partners. So myself, our care management organization, and our family-based organization do what we call road shows all around the county, where we will go to schools and we will talk about how to access services and what each line of service looks like, and how we can help them, and how we can help the schools, the teachers, help the families access the services. I personally am involved in a police officer training program. So quarterly, I am part of a program that goes and helps train our police officers about crisis intervention. So in that programming, I talk with police officers, I tell them about mobile response, I explain to them how to access mobile response when they're with a family that needs it. And in those moments before we actually have the formal presentation and after, I actually get to meet with the officers and make relationships. And from that, a lot of departments have actually just invited us back to do private presentations with their police force, just to have more interaction with more officers. So this is really great. We see, an uptick in the officers actually helping families call, and this really keeps those kids out of the juvenile justice system, which is really important. PTA meetings. So we have gone to lots of PTA meetings and spoken at the PTA meetings, put up a table during back to school nights and have information. That's a great way to sort of partner with the communities and meet the parents out there. Local pediatricians, they love when we visit and we drop off information, because, they are having their patients fill out some wellness forms at the beginning of their visit. And a lot of times they're, they struggle with who to refer to. And so we're quick. They can have a call to us in the office. We can set up the appointment before they leave their pediatrician, and they know that they're going to be seen. So it's a really nice partnership with those pediatricians. And of course, we want to have a good relationship with our emergency department heads, the screeners of the screening departments there. Next week, I actually have 3 meetings scheduled with 3 different hospitals and their screening managers. Those relationships are so important to really to have and to nurture. Unfortunately, some kids do get referred, and Tim had it on one of his slides by schools, when it's unnecessary. And when the kids do wind up in the emergency department, knowing that there's this mobile response program they can refer them to, so they get what they need, but not that intensity, is really helpful. So having those relationships with the emergency departments are really helpful, so that we know that when they aren't admitted and they don't need to be admitted, that we're there and we can go and see them later. So I think that's a really important partner to get yourself involved with. In closing, mobile response is not a program or service that operates in a vacuum, and that is really what makes it successful. Our success lies in our strong community partnerships and our ability to rally around a family and support them when they need it most. And that is really simply by meeting them literally and figuratively where they are, and going to meet them at the time that they ask for help, and mobilizing all of the community supports that are out there already, so that they all can be part of that orchestra that I talked about earlier, so that we can work in harmony to help a family and to help a youth really achieve all that they're able to achieve, and work up to their potential and just live a happy, successful life. And with that, I want to thank you for letting me speak with you today.
Yeah, hi everybody. I want to thank our presenters, Tim and Danielle, again for that great presentation. And now my name is Matt St. Pierre. I am a director at the National Council, and I'll be moderating today's Q&A. We had a very active chat, and we have about 20 minutes for question and answers. So first one that came in was from Katie. Came in during Tim's portion, but I'll open it up to both presenters. Have you experienced crises that are appropriate for a higher level of care? And in that case, do you triage?
I'll go first, and then I'll let Danielle go. So in Connecticut, so there's two moments where that could occur. The first being on the original call. So if the caller is describing an acute situation, we try not to refer directly to the ED or to send active rescue from the call if possible. But if there's the information coming across warrants it, then that might be the response. And that does happen, and not a lot every year in Connecticut, but it does happen. The preference would be, even if they think that the child might be acute enough to need to be hospitalized, is to go and do the face-to-face anyway, and then offer support and transition from the home or the community to whatever the hospital is or the emergency department is. Particularly if they have to go to the emergency department, staff are able to stay with them if they can. Sometimes the other calls and coverage and all that gets a little bit challenging, but if they're able, they can at least help with that. But the biggest thing they can do is help prepare for what it is. So yes, it happens, but it is preferable to be face-to-face to do that assessment versus trying to determine whether the child needs to go to a higher level of care by the second person, the third party that's calling, usually a school or parent.
Right. I'm going to echo a lot of what Tim said. So for New Jersey, the call comes through to that CSA that I spoke about. And again, if it rises to a level of emergency medical treatment has to be dispatched, that happens. But once a call comes through to mobile response, we do not turn down any calls. And again, we will go out, we will do the face-to-face, the assessment. And then, yes, if something needs to happen in terms of a higher level of care, we'll help make that linkage for the family and try to make that transition as least traumatic as possible. But again, we're looking to see if there's anything we can do other than that. But we would not just triage if it came to us and do something else. We always would go and see them.
Okay, thank you. And next question came in from Andrew. You indicated you have a youth mobile response team available 24/7. Do you also have an adult mobile response service available in your state? And if so, how does your state support workforce staffing for both types of teams across the 24/7 model?
Yes, again, Connecticut has both. Connecticut has a child serving system, and that falls under the Department of Children and Families. In Connecticut, we're integrated. So we have protective services, a little piece of the juvenile justice, and then there's mental health and substance use under the same roof. So we have the responsibility for the mobile youth component. The other state Department of Mental Health and Addiction Services, has the responsibility for the adult. Both of those are 24/7, and they're supported differently and separately through different expenditures under the general fund, and there is third-party reimbursement. The workforce component of that can be challenging, particularly these times, but I'm only familiar with the child serving, can't speak for the adults. But in Connecticut, I believe the current staffing tends to be pretty good. And there is a strong workforce development component, I believe, under both systems. So quite a bit of offering training and workforce development opportunities throughout the year to make sure that the staff are fully competent in a number of areas. Thank you.
Yes, and in New Jersey, we do have an adult component too, and I am not all that familiar with it because I really tend to work more with the children, but it's actually very easy to access, and so they can anybody can kind of call to do a wellness check for an adult, and they can have the screeners. And with adults over 18, though, the police do accompany them on those screening calls in New Jersey, and those screeners come from one of the local hospitals and go out and accompany the police.
Thank you. And then there's definitely some themes developing in the Q&A, and in the interest of time, I might blend a couple questions together along some of these themes to try to cover as much ground as we can. So the themes I'm seeing are workforce and funding for sure, and kind of like training / workforce wellness. So I guess the question is like, how are you staffing this? Has it been difficult? We know there's like a workforce shortage. Are you prioritizing some things over another? Or just how are you kind of meeting that challenge of staffing and retaining staff?
So in Connecticut, I know during the pandemic, there was a big challenge. And I think all of the executives of the 6 contracted agencies have had challenges to continue to keep them fully staffed. All of our programs are embedded in full continuum service organizations. And so my sense over the years, just from the familiarity, has been that they frequently will recruit people from other parts of the agency when they go down staff, if they're able. That said, there are almost always some openings, but generally speaking, the staff coverage that agencies have cover the need that they have. Now, there are times when it dips lower and they really got to scramble and they're doing a lot of per diem, or they're paying people overtime, and they got to do whatever they got to do. So I'm not going to say that workforce is never a challenge, but the one thing I will say about the workforce that is really, really important, if you don't feel competent in doing what you're doing, you're going to have turnover. And I would say that that's a magnifier in crisis services. If you don't feel like you have the skills to be working with kids and families who are in crisis, you feel inadequate and you feel incompetent, and that is not a good feeling, and you don't tend to stick around. So we put quite a bit of emphasis on workforce development, and I just will say there's 2 major themes that I think that are really important. Suicidal ideation, and being very, very competent in that is really, really important. 2, being very competent in your basic wraparound, high fidelity wraparound principles, particularly in developing a plan of care and, a unique, keeping families at the center of their care, and using natural and informal supports. I think that's really, really important. And then making sure you have workforce development opportunities that touch upon all of the special populations. Because if you go out and if you're working with somebody who has got ID or DD or struggling with gender or sexual orientation issues and you have no experience in that, again, you're going to feel incompetent. You're going to want to turn over and move on to something else. So workforce development goes hand in hand with the workforce recruitment and support and retention. So I'd say that. Danielle, to you.
And I think a lot of that is really true for New Jersey too. So of course, during the pandemic, we did have struggles with workforce. And that was really difficult for lots of reasons. Currently, though, we're in a really good place with our staffing, which I think is just, it feels really good to be in a good place. And I think, Tim, I think you're right. I think what I think has kept the staff that stuck with us during the pandemic and the new staff we brought on is really training. So in New Jersey, we call our mobile staff crisis intervention specialists, and they're required to do a number of trainings each year. And that's important, right, to help their competency and their confidence. And Tim had said that the summer is a little bit slower for us. And so we spend a good part of our time doing trainings in the summer and utilize that time to really help the staff. So I think that's a really important component. And to your point too about per diems, right? So we want to make sure we don't overwork the staff that we have. And so if we have per diems that are on hand in case the call volume in any given day or night is a little overwhelming, that we can use those per diems to really help back up our staff so that they don't feel overwhelmed or overburdened. So I think that's another factor too. So I know Tim covered a lot and there might be other questions, so I'll stop there.
Yeah, one kind of question related to that we saw was like with workforce, what level of experience are you hiring? You both spoke very much about like the training that you folks go through when they're on the job to help ensure competency and how much time is focused on that. But in hiring, are you hiring bachelor's, master's, only licensed level? What's that like?
Yes, in Connecticut, on the clinical assessment side, we require master's trained, licensed or license eligible. Connecticut's contract in the contracts with the providers allows for peers or paraprofessionals to be hired to be a part of that. But the primary intervention in the acute phase and the follow-up needs to be done by the master's level, and then the peer and or paraprofessional can stay on and support the family into further context in the stabilization part.
So in New Jersey, to be a crisis intervention specialist, you need a bachelor's degree with a few years experience. For our agency personally, for a long time, we were only hiring master's level staff. But we actually have since sort of looked at that a little bit. And if we've hired some bachelor level staff too with years of experience. Now, all of our supervisors have a clinical license, and the staff are divided amongst all of the supervisors. So everyone is getting weekly supervision, as well as are accompanied by supervisors out into the field so that they can get some hands-on training as well. But yeah, we do both bachelor's and master's level.
Mm-hmm. Great. I'm going to try to hit two other questions that came through. I did want to highlight that this was answered in the chat about, can families reach your programs by calling 988? And both said yes, 988 links to the program. So just wanted to highlight that. But then we had the question come in from Tanya. It would be great to learn more about the 23-hour crisis stabilization centers and how these work for children and adolescents. Again, what does staffing look like? Is there data on the cost of setting these up and staffing them?
Yeah, actually, I think there might have been an executive too on from Connecticut that I noticed. I'm working with some of those executives to see if a future presentation is in the cards. They're newly implemented. They're still early in their data. I think the whole system has seen about 500 or 600 kids. If I understand correctly, there's 4 of them. 3 of them are community-based. One's a hospital-based. And if there's interest, maybe in the future, we'll see if we can pull that off.
Well, that's exciting to hear. And then Danielle, this one came in from Carol. what are the steps of linking families with a therapist? Like, once the family's linked, does the therapist have access to the assessment and plan? And if a family's already enrolled in wraparound or receiving some type of service, how did they coordinate?
So we have a central chart that both the mobile response program and the therapist, if they're the in-home therapist that we staff, have access to, which is really nice. So it's one place for us to do all of our documentation. So what happens is once we meet the family, we kind of think about what kind of therapist might be a really good fit. And we have a whole host of therapists with their specialties. So we'll go ahead and figure out which therapist is a good fit, and then we'll make a formal referral to them. We put the authorization through that shared electronic record. The therapist will see it, and then they'll contact the family. Part of what I had spoke about in terms of that weekly coordination is we're reaching out to that therapist on the weekly basis and checking in with them, as well as checking in with the caregiver and the youth to make sure, you know, that the services are happening, what might be needed in terms of support, or sometimes maybe that first appointment doesn't happen right away, and how can we help get that sort of going. But yeah, that's how it works. Now, in terms of if they're already receiving wraparound services, so that would probably mean in my case that they might already have CMO level of care or case management, and they cannot have care management with someone else and us. So it's one or the other. So if they call through to perform care, that system administrator, they can see what they might have already, and then they're able to link them to their care manager. So that 1-800 number can help link people back to who they're connected with if they forget how to get that. I think that might, if I didn't answer it all the way, let me know.
No, I think that's great. I want to be respectful of everybody's time. I know we're coming up on 2:56. So I want to thank our speakers again. I also want to let the audience know that this webinar is actually part of a series. So if this content was interesting to you and you want to learn more, keep eyes on your inboxes for announcements for future dates on crisis stabilization webinars from NASHVID, the National Council, and more. And with that, I will pass it back over to Kelly to close us out, and thank everybody again for coming today.
Thank you, Matt. I would like to take this time to thank our presenters, Tim Marshall and Danielle Gasparini, for joining us today. Thank you so much for your presentation. And I'd also like to thank SAMHSA for allowing us to share this information with you. As you are exiting the room, please fill out the survey and let us know what you thought about today's presentation. Thank you all for joining us, and enjoy the rest of your afternoon. Take care.